Good morning, everyone. I see some new faces, so I guess I should introduce myself. I'm Tymon. I'm one of the fourth-year residents. My talk today is going to be on principles and advancements in facial reanimation, um, which is a really relatively nascent subdiscipline of facial plastics, which I think has a lot of room for innovation and growth, which I find really exciting. Um, so to begin, I'm just going to give a little bit of background on facial nerve pathology. And then given that this is a field that tailors very specifically to specific patient needs and preferences, I wanted to review kind of the diagnostic considerations and surgical techniques for the interventions that we currently have. And then shortly with the discussion of the future directions and exciting advances on the horizon in terms of facial reanimation. So to provide some background, the facial nerve is the most commonly injured nerve in the human body. Facial nerve paralysis affects 20 to 30 people per 100,000 annually. And the most common, as most of us are aware, is from Bell's palsy. But other etiologies in our kitten's mnemonic include congenital causes such as Mobius syndrome or golden heart syndrome, and also iatrogenic causes, as we're all familiar with. The most common of which actually comes from the oral maxillary surgery space, followed by head and neck procedures, and then otologic procedures, and a small subset actually is from primary facial nerve tumors themselves. Trauma can also be an etiology, and that can vary from crush injuries or blunt trauma to penetrating trauma, infections such as Lyme disease, neoplasms, and then also systemic diseases such as nerve ischemia, from like angiopathies, and also, for example, Guillain-Barré syndrome. So the effects of facial nerve paralysis have a wide spectrum of severity and also effects across the face. With the loss of facial nerve function, there's pathologic relaxation and drooping of the eyebrow, the eyelid, the cheek, and the corners of the mouth, just to name a few. And with that, with the ocular components, you can have like ophthalmos, lid retraction, inflammation of the eye or keratitis, and ultimately vision loss if it's not well managed. Oral incompetence, dysarthria, problems with mastication can also ensue, and also nasal valve collapse and nasal obstruction can happen because of the denervation of the dilator nares and also the levator superioris. And then, of course, there's a loss of facial expression. Synkinesis can also occur, which is the aberrant regeneration of nerves, which causes dysynchronous firing and involuntary movements. And so the psychosocial implications of this disorder are pretty great, because facial expressions play such a major role in the way that we communicate with each other, and can really give rise to feelings of social isolation and depression in people who are affected. We know from the literature and surveys that there is increased association with self-esteem problems, depression, decreased quality of life, and increased social burden for patients who suffer from this. And surveys also show that people perceive patients with facial paralysis as less trustworthy, sometimes less intelligent, and also distressing in their appearance. For our more junior residents, I specifically wanted to emphasize the ocular sequelae and the importance of protection because of the potential for devastating complications that can be avoided. So factors that can increase the risk of keratitis and ultimately vision loss are a couple of things: absent Bell's phenomenon, corneal anesthesia, and a history of dry eye. And Bell's phenomenon is a compensatory protective mechanism that draws the eye upward and outward upon eye closure attempts, which this gentleman is demonstrating here. Therefore, protective eye care is critical, and first-line treatment for that is artificial tears, followed by some lubricating ointments, which can disturb vision and are generally administered during the night. And some sort of physical barrier, whether it's a tape or eye chamber, is also important. The problems with eye protection occur because of the atonic lower lid and malpositioned lacrimal gland, so that the punctum fails to distribute an even liquid film across the cornea that protects it. It's also the same reason why epiphoria occurs, because the drainage mechanism is faulty. So when we talk about facial reanimation, we have several goals, one of which, of course, is ocular protection, followed by restoration of the nasal airway and nasal breathing, also to restore oral competency, and then, of course, to improve facial symmetry, and also the ability to involuntarily and voluntarily express emotions, including a smile, also to limit synkinesis and other involuntary movements, or undesired involuntary movements, and also to limit the donor deficit from whichever interventions that we prescribe for our patients. As clinicians, when we evaluate the facial nerve for injury, there are several criteria that we use generally. The House-Brackman scale, for example, which is a good assessment for overall function, but does not really precisely assess the effects affecting one or more of the branches, nor does it really allow for evaluation of the success of our treatments. The FACE scale is a quality of life measure that largely revolves around the effects on the patient's quality of life in regards to vision, or competency, etc. And similarly, the synkinesis assessment questionnaire, it relates to the involuntary movements from synkinesis. The patient's overall health status is also really important to note, because it greatly affects the repertoire of the interventions that we're able to offer patients, and we'll discuss this in a little bit further detail later. Once damaged, the facial nerve rarely regains complete function, and currently no modality satisfies all the treatment goals that we talked about. Even in the event of a perfect surgery, or in the immediate setting, this is an unlikely goal or unlikely result. So that should go into our discussion with our patients, and temper their expectations. So when we evaluate the facial nerve for injury, really there is currently no ability to evaluate the viability of the proximal segment via electrical testing. We're basically only evaluating the neuron and the attachment to the motor neuron endplate. So the proximal nerve viability really depends on the nature of the injury. For example, whether it's a crush injury or a penetrating injury, in which case there could be transection of the entire nerve, as demonstrated in the Sunderland class 5 classification, and also the location of the injury along the course of the facial nerve, whether it's at the distal end or at the main trunk, or even more proximal to that. And then age is an important determinant of the regenerative capacity of the nerve, and the patient's nutritional status, comorbidities, also radiation history. And it's important to note that electrical stimulation can only identify the injury or the innervation of distal nerve branches within 72 hours of injury. After this time, only visual identification is reliable. So as a practice, we should be in the habit of basically tagging these transecting nerve branches with some sort of colored suture, if there's an expectation that there will be some sort of reanimation procedure or re-exploration, so that these branches can be easily found at a later time. So there are several facial nerve landmarks that we're all aware of. There's a couple additional ones from a review by Bernstein and Nelson that describes helpful landmarks and the variability of the facial nerve branches. The first one that we're all quite aware of is the tragal pointer, which locates the pes, the main trunk, about a centimeter and a half deep to and 1 centimeter anterior and 1 centimeter inferior to the tragal cartilage. Petangales line, which is in reference to the inferior aspect of the EAC, connecting creating a line to the lateral aspect of the lateral brow. The tympanomastoid suture line is also used in addition to the posterior belly of the digastric to determine the plane of the facial nerve. And then in some cases, when there is a very proximal injury, the mastoid segment, the intramastoid segment can also be used, in addition to retrograde dissection of the terminal branches. And then one other landmark is the passing of the buccal branch, centimeter inferior to the lower border of the zygomatic arch. So considerations in choosing rehabilitation options for our patient. The time and the onset of the injury is really important. There is significant atrophy of the nerve and the motor neuron end plate after 18 months after the injury. And so depending on the timing of the injury and the etiology of the injury, that can affect your and proposed intervention. For example, if you have a tumor ablation with facial nerve sacrifice, you can immediately repair it with a, for example, a cable graft if you can't perform a tension-free anastomosis. But then in cases of a questionable nerve continuity and viability, like after a CP angle surgery, you may elect to wait. So how to proceed should also largely be based on the current status of the patient and their facial nerve and the availability of a viable proximal facial nerve segment. Like I mentioned before, the patient's age also matters quite a bit because neuronal regenerative ability declines with time, as is well established in the literature. Most patients with injury-related neonatal paralysis, for example, with intrauterine injury or birth trauma, recover spontaneously most of the time, whereas those, for example, with congenital anomalies are more permanent. So in those cases, nerve transfer procedures are futile interventions. Again, patient comorbidities is important because, for example, diabetes and microangiopathic pathologies significantly impair your regenerative capability. Consideration of the patient's current and impending treatment plans, especially, for example, if they are to undergo radiation, is important to consider. Successful nerve grafting after irradiation has been reported. However, a study by Pillsbury and Fish found that radiotherapy reduced nerve function recovery from 75% to around 25%. And specifically, irradiation of the pontine nucleus, which is the most radiosensitive portion of the course of the facial nerve, should be taken into consideration. So when we look at testing nerve viability, 4 main electrodiagnostic tests are used. And we mostly focus on EMG because it's the most commonly used and it's also, I think, the most testable in terms of in-service questions, but we'll review all 4 of them. So the first is the nerve excitability test, or the NET, which uses an electrode on the skin to assess for stimulation and movement. And the result is interpreted by a rater, so it's largely subjective. And it's important to note that it's really only useful in the first 2 to 3 weeks of injury because of Bell's degeneration. Similarly, the maximum stimulation test also is very subjective and assesses the maximal or the threshold required to create maximal movement. and it's compared to the contralateral normal side. And so it's generally a percentage of the normal side. ENOG, or electroneurography, is another modality that we can use, which is more objective. Excuse me. And it involves using a stimulating electrode in the stylomastoid foramen, and then a recording electrode in the nasolabial folds. And in general, 95% nerve degeneration or above implies a poor prognosis for the return of function. And it's useful from 3 days after injury to about 3 weeks. And it's important to note that it's not useful in cases of incomplete paralysis. And lastly, electromyography, which can be used starting from 14 days of onset of injury. So to describe this a little bit further, there's several types of interpretations of the results of EMGs. The first is normal voluntary action potentials, which implies that there's a functional motor axon stimulating a functional motor unit. And then the second is polyphasic potential, which is electrical evidence of reinnervation, even in the setting of no physical evidence of reinnervation. Within a year, this finding implies that there's a potential for further regeneration, and beyond the year, it's considered stable. So if you are considering a procedure for a patient within a year, observation may be prudent because there may be further regeneration, and the patient's facial nerve function may not be indicative of their final ability. And then if you see fibrillation or denervation potentials, that signifies a normal but denervated muscle. And for example, in those cases, like a 5-7 masseter to facial nerve transfer may be indicated. And then in the setting of electrical silence, that demonstrates either atrophy or complete absence of facial muscles. In those cases, nerve graft or any sort of transfer is futile and therefore contraindicated. And something like a muscle microneurovascular transfer may be necessary. So just as how we have a reconstructive ladder in head and neck reconstruction, there's kind of a general order of interventions that we should try and follow when looking at interventions for facial reanimation. The first is observation, waiting for the patient's final innervation pattern to present itself, followed by neuropathy, cable grafting, nerve transposition, muscle transposition, microneurovascular transfer, and a static procedure. Of course, the optimal source for reinnervation of the paralyzed face is the patient's ipsilateral facial nerve, and that should be pursued if that's available. And then a lot of these procedures can and are performed in conjunction, depending on the patient's needs. Oftentimes, especially in the head and neck setting, there is a situation where there's sacrifice of the nerve, and there needs to be some sort of selective rerouting of the innervation. And if that's the case, then there's a priority of reinnervation that we should follow, starting with the buccal and zygomatic branches, followed by the marginal mandibular branches, the frontal, and then ultimately the cervical. In regards to primary nerve repair, this should always be done in a tension-free manner in order for regeneration to occur with a 9 or 10-0 monofilament suture. And the suture should really only pass through the epineurium, and it's advised to have about 8 to 10 millimeters of extra length in a lazy S configuration to ensure this, this tension-free repair. As you can see here, there's different techniques that you can do. The best of which is an end-to-end repair. However, an end-to-side repair or a side-to-side suture can also be viable. There's also description of basically interfascicular nerve repair in the literature, which is basically repairing each fascicle individually. And this is notable in the nerve repair literature for extremities, but it doesn't really apply for facial nerve repair because depending on which segment of the facial nerve you're in, there may only be one or two fascicles. So cable grafting is most commonly done in combination with another procedure. For example, with an ablative procedure like a radical parotid or a temporal bone resection. And it requires a identifiable proximal and distal nerve for you to connect together. And it can offer additional length to other modalities. The most common donor nerves that are used are the greater iliac, the sural nerve, the cervical plexus, and then the medial antebrachial cutaneous nerve, which is more described in the orthopedics literature. In the case of the greater iliac, the contralateral nerve should be used, and it can be identified from its origins from Erb's point. Its advantage is that its size and fascicular pattern is similar to that of the facial nerve, but it's very short. It's about a 10 centimeter segment. Of these options, the sural nerve has the longest possible segment of up to 70 centimeters and is harvested starting from the lateral malleolus. And it's interesting to know that all these are sensory nerves, which can in fact undergo regeneration, reinnervation with motor nerves. And the reason why we don't use motor nerves is because obviously it will create some sort of donor site morbidity from whatever we take. The next intervention is cross-face nerve grafting, which is first described by Scaramella and Smith in 1971. And it's the only modality that allows for specific real divisional control of facial muscle groups. And it requires the transection of several fascicles on the contralateral side, usually via a nasolabial fold incision. The nerve graft is then tunneled through the upper lip, and then the subsequent attachments are made to the ipsilateral branches. And this requires multiple stages. The first stage is usually pursued about 6 months after paralysis, and then you have to wait up to a year for regeneration to occur. And tinal sign, which is tingling sensations with tapping of the nerve, can be seen after several months, and it's a very affirming indicator that reinnervation is occurring. The disadvantage is that it takes time, and that there is a poor axon population and excitability of these nerves. So in general, these are usually only used with other techniques like muscle transfer, for example. Nerve transfer is pursued when the proximal facial nerve is non-viable, and the most well-known of which are the 12-7 and the 5-7. Other nerves such as 11 and 7 and the phrenic nerve has been attempted in the past, but they have not demonstrated satisfactory results. And as a useful rule of thumb from Dr. Moyer's didactic lecture, the hypoglossal nerve or the hypoglossal transfer can be considered to provide superior tone, while the masseter generally provides superior power. Both of them can be accessed through a modified facelift or parotid incision. And the hypoglossal facial is useful because of the close anatomic proximity of the two nerves. And generally, the results are quite good. The largest series has 137 patients, and 95% of them regain satisfactory tone to the affected side of their face. The problems, though, are that there's a lack of voluntary emotional control, and also tongue atrophy can occur for some patients. For the masseter facial, the nerve is found as it passes generally between like the condyle and the coronoid process. For the masseter, it requires voluntary control and training in order for you to express emotion. So I just want to play a quick video. So this is
One
a
more
patient
time.
who
Right.
underwent a macerative facial
I
transfer.
want you to bite your teeth together for me and relax. One more time. Relax. One more time, bite down hard. Great. For me. And relax. Big smile again. Perfect. Relax. One more time. Great. Relax. Big smile. Relax. One more time. Relax.
Pretty amazing. Okay. So the next intervention that's available is muscle transposition. So this is utilized when the proximal facial nerve is non-viable or the facial muscles are absent or atrophied, and it doesn't allow for emotional or involuntary reanimation or control. The two that are generally described are the masseter transfer, which is ideal for lower face and mid-face rehabilitation, and it can be performed through a parotid or a gingival buccal incision, and the muscle can be divided up to 3 segments, which can attach to different parts of the lower and mid third of the face. The temporalis transfer is also similar, but this one allows for upper and mid face and lower face control. It can be divided up to 4 segments and can be attached to the orbicularis oris. The muscle itself is tunneled over the zygomatic arch, and as a result, the creation of the tunnel is important because otherwise, if it's not done properly, it can create an unsightly bulge. And then also there's a residual temporal hollowing from the donor deficit, and that can be filled with a TPF flap or some sort of silicone block. The next option is microneurovascular transposition, and it's indicated when the patient's facial musculature is absent, for example, in the setting of Mobius syndrome. And the most common that we use is the gracilis, which is the medial adductor of the thigh. The problem, despite it being very robust, the vessel size is quite small, even for microvascular surgery standards. And there have been single or double stage procedures described. Generally speaking, they're double procedures where there's a preliminary cross-face graft coupled with a microvascular muscle transfer a year later. There are other options for muscle donor sites like the latissimus dorsi or the pec minor, but in general, I think the gracilis is preferred. And then it's important to note that the activation really depends on where the power derives from. And it generally comes from either the masseter or a cross-face graft. So just want to play another video where this is basically intraop description of the gracilis muscle flap.
In this particular case, we want to have anchorage of our sutures into the oral commissure, and we want one to go into the lower lip to support the lower lip, to improve upon this boy's oral competence, his speech, because the lower lip can lift up to help with bilabial speech, and of course to create an animated smile with an appropriate nasolabial crease.
So here he's describing the importance of the location of the anchoring points, so that there is a satisfactory expression with the pulling of each of these sutures in their respective vectors.
Sutures have to be placed in precisely the right location. If they are too superficial, they will evert the lip. If they are too deep toward the mucosa, they will invert the lip. So they're placed through this sinewy, firm, fibrous kind of tissue, and then we test it by traction to see the exact movement of the commissure, lower lip and upper lip, making sure that it is the precise movement we want. The uppermost suture into the upper part of the upper lip is the hardest to achieve, difficult to get access, and sometimes it's helpful to place the finger inside the mouth in order to try to place them again.
He seems pretty happy. Okay. So we talked about mostly we've covered mostly all the different nerve transfer procedures. One thing that I didn't mention yet is the use of like static slings, for which the tensor fasciculata is a pretty good candidate. There's also adjunctive procedures that we can use to treat the paralyzed face. And I think one helpful way to break it down is basically to break it down into the upper and middle and lower thirds. So for the upper third, you can commonly encounter brow ptosis, or kind of lid lag, as a result of the paralysis. So patients can sometimes benefit from a direct brow lift, sometimes blepharoplasty, and as we're all quite familiar with, I'm sure, is gold weight placement for the upper lid. You can also place palpebral springs and slings, which basically serve a similar function. However, they, I think, have a higher likelihood of extruding, but better conform to the shape of the lid, which is sometimes one of the complaints of having a gold weight, is that there's a visible foreign body in the lid. For the lower lid, there's a couple of different techniques that you can utilize. The first of which is a tarsal strip technique, which basically isolates the lateral tendon, and you denude the conjunctiva over it, and you suspend it to the lateral orbital rim behind Whitnall's tubercle. You can also combine that with a canthopexy. You can also use a lower lid sling. And in instances where rapid protection of the eye is necessary, a tarsorrhaphy can be performed. For the middle third, we're mainly concerned with the nasal valve collapse, but also just the general appearance that can result from paralysis. So a static sling can be used for nasal collapse, which pushes the nares wider. And then rhinoplasty techniques like alar batten grafts can be used. And these occur because of the loss of the intrinsic dilator nares tone, which causes the collapse. And one other thing that can occur is the ptosis of the palpebral malar complex. And there's bulging, as we can see here, of the lower eyelid fat and descent of the SOOF, or the suborbicular oculi fat. And so procedures like a mid-face lift, where you reposition the SOOF using like a transconjunctival incision, can reduce the appearance of these. For the lower third, again, the main concerns are oral incompetence, drooling, air escaping during speech, difficulties with mastication, and these can actually be worsened by mid-face procedures because of the way that they pull the lower third of the face. So wedge resection can be performed, where a full thickness excision of part of the lip can be performed, or cheiloplasty. And then one interesting procedure that I came across is a digastric transposition, which is basically using a submandibular approach to the digastric tendon, releasing it from the hyoid, reflecting it, and then securing it to the oris muscle. And then it's more to note that obviously this requires an intact belly of digastric muscle, which is not always the case with some of our patients undergoing treatment. I also wanted to talk about kind of things on the horizon in the facial reanimation space. A couple things I wanted to point out. One is the advancement of bioprosthetics, biomaterials, leveraging cellular regeneration and molecular signaling research. And then I guess as some of you have probably heard the use of like facial transplants from donor patients. In terms of bioprosthetics, there's this recent article by the Hadlock group from Mass Eye and Ear, where they implanted an electrical prosthetic device in mice with iatrogenic hemifacial paresis. And the prosthesis was used to create eye blinks and wisps of the nose and the whiskers. And they were basically able to match the electrical inputs that they gave to the mouse to the outgoing muscle signals. And they matched about 96% of the time, which is pretty cool. And so we can potentially see this as a future implantable device for patients with facial paralysis, where there's a wireless electrical signal that sends inputs to the other side and creates electrical impulses. Of course, there's a couple of considerations to think about. One is how to generate the degree of power to stimulate a nerve with a small device that is not noticeable. Also the size of the device itself, and how to synchronize multiple muscle groups firing at the same time to create a normal emotive expression. In terms of biomaterials research, a common theme that I came across in the literature is the combination of multiple biomaterials to enhance nerve regeneration. Basically, I found several studies where there's a combination of biologics, some sort of polymer that conducts electricity, growth factors, and then select cell populations to induce nerve growth. So in some studies, I found use of cross-linked collagen, the polymers that I talked about, nerve growth factors, and culture swan cells. In others, I saw the use of like adipocyte-derived stem cells and fat cells that were able to increase nerve regeneration in animal peripheral nerves. In one study, they described recurrent laryngeal nerve regeneration in animal models using a combination of collagen scaffolding, silicone particles, and polyglycolic acid. So we can potentially see this as an adjunct to the surgical interventions that we have now, in the same way that we use nerve wraps for our nerve anastomoses. The other thing is the other findings are basically leveraging cellular regeneration and molecular signaling and our understanding of those in our favor for nerve regeneration. So GDNF, which is a glial cell line derived neurotrophic factor, in combination with VEGF from macrophages, released in certain conditions, improved in vitro nerve regeneration. And then in other studies, stem cells from fat and bone marrow derived stem cells were able to bridge a buccal nerve gap in animal models. And then I think just as important is to understand how to inhibit regeneration, because in event of aberrant regeneration and synkinesis, it's important to know how to control that as well. So certain studies describe the use of vincristine and myelin-associated glycoprotein to inhibit facial nerve regeneration. So all things that I find pretty exciting. And with that, I just wanted to play this last video of this patient with Mobius syndrome who had a massive
There's an extraneous muscle in the upper part of the thigh. You can put this muscle and position it. I mean, you do it on both sides.
They cut me open to put this in. So that's how I got my smile.
Pretty cute. Okay. That's all I have. So I'd like to open the rest of the time for any comments or questions or discussions.
That was a great talk. Great job. That's a lot of information packed into one lecture. But I think you really hit the critical parts. This is a tough population to treat. I think because of what you mentioned early on, how, you're talking about emotive ability. And so this is very emotional for patients. And the time that I spend in clinic with these patients is much longer than for any other patients that I see, partly just, doing a bit of hand-holding, getting them through this process. And I think, a lot of it is really setting expectations. You want to give them hope as you're kind of waiting for things to regenerate. And then those time markers, you talked about EMGs around a year, more and more we're really pushing for earlier intervention. So I think it's important to see these folks earlier and to maybe be a little bit more aggressive than we used to be with some of our nerve transfers, because it's important to keep in mind that you're not, in most cases, transecting the nerve at its base there. You're reinnervating distal branches. So you're not always burning bridges when you do that. And the other comment, about regenerative potential, that's a really interesting area in facial nerve that I'm really curious about, because it seems like these patients, particularly with masseter nerve transfers, even the older patients, you look at like 60 years old and above, we're working on publishing something from our Jefferson experience where those patients do very well. And I think there's historically been a thought to kind of maybe do less for some of those patients, but I think we should be offering exactly what we offer to our younger patients, especially because those patients are the ones most prone to withdrawing from society with any kind of sensory hit or motor function hit. If they're not able to swallow, they're not able to hear, they're going to be pulling back from society even more, and that's been correlated with mortality. So did you I know this was like a lot for one topic, did you get much into synkinesis or treatments for that?
Yeah, and I kind of looked in the literature in terms of like using Botox or like even like myectomies in some cases, but I just thought it was a little much.
Yeah. I've never done that digastric transfer. I've read about it. I've heard people talk about it, even at the conferences. I don't know anyone who actually does it in practice, but it certainly gets talked about.
Yeah.
JP did one. It worked awesome.
Did it?
Yeah, it was great.
Who did he do it for? What kind of patient was it?
It was a skin cancer parotid resection, and the trouble is that it's for at least for that population, when they've been radiated, it's the neck's kind of a rock, and it's questionable whether it's going to be functional.
Yeah.
But in the one patient we did it, it worked awesome. So
cool.
it's I think a good option if in the right patients.
Yeah, I'll have to ask him about it.
I mean, that was a wonderful talk. Thank you. It just reminds me back when I was a resident, everything related to the facial nerve was otology. And now it's just changed. I mean, I can't imagine the last time I've really done a facial nerve reconstruction because the facial plastics and reconstructive surgeons have taken over that, and they've expanded it so much. I think it's so much better with people that are kind of dedicating their time to it. For us, it was really just trying to fix a complication that we caused. And it would basically be a 12-7, and if you were going to be fancy, you'd do a jump, like a split 12-7 with a jump graft. It's just wonderful. I think the 5-7 works really well. But there's a lot of room for disruption in this. Unfortunately, I think it's going to be a hard problem to fix because it's not like something that's hidden under your clothes, right? Everybody sees it, and it's hard to, if it isn't perfect, people notice even subtleties, and it's going to be hard to ever make it perfect. But I think what's happening now is terrific. So thank you for that great summary.
Thank you.
Yeah, Tymon, this is Dr. Mark Carrion. Great talk, and I think you hit all the good points. And so these are tough patients, and we have to have a lot of tools in our toolbox. So anyway, good job.
One other comment from...
Oh, sorry. It's Mark Swanson. I have one quick question. So you mentioned that patients who have radiation have less of a outcome for nerve grafts and transfers and stuff. Is that patients who are radiated and they try and do a facial reanimation afterwards, or is that patients who have an ablative surgery and reconstructive the same day and then get adjuvant radiation?
They had a reanimation procedure and then were radiated afterwards.
Got it. Thank you.
Yeah.
Just one other comment from the head and neck standpoint. I think we've, over the last couple of years, we've been doing a lot more upfront facial nerve reconstruction, and some of that, especially for the big defects, has included an ALT flap. You can take your motor nerve with the flaps and use that as your donor, as your nerve, and then it also fills in a lot of the volume. So we've definitely been, more aggressive with our reanimation up front as opposed to waiting till they get radiation, going back and doing the slings and stuff like that. And I think it's certainly helped. So.
Yeah, I think that's a good approach, because post radiation also there is so much devascularization of all the nerves, the vasa nervosa. So chances of recovery is much less as opposed to doing it upfront. Like I've done several in the past. Serratus anterior, for example, used to work very well with all the several tendinous portion of the serratus, but the upper and the lower eyelid and